Good morning, everyone. So we have already discussed in detail about the axial length calculation and the keratometry. So how do we apply these two now to calculate the IOL power? So cataract surgery in today's era is not just about removing the cataract, because it has become a refractive surgery, because patients, they expect a vision of 6 by 6 post their surgery, right? So calculating the IOL power correctly is very, very important. So what are the components in that is the biometry, the formulas that I'll be talking about. There are certain clinical variables and the effective lens position. So briefly discussing this again, which has been already discussed, the biometry mainly includes your axial length and the keratometry. The axial length further can be measured either by a A-scan ultrasound or using a optical biometry, right? And in the A-scan, we have already discussed there is applanation and immersion. So what is the importance of axial length in your IOL power calculation? You have to always see that the axial length is measured for both the eye, even if you are doing one eye surgery. Why? Because if there is difference in the two eyes of more than 1 millimeter, that means there is something, right? So either you need to repeat it, you need to confirm it, whether you have measured the axial length correctly or not, or there should be some pathology which will tell you that why the difference is more than 1 millimeter. Okay, and another thing is normally the axial length should be between the range of 22 to 24.5 millimeter. Now why is this important is because if the axial length is less than 22 millimeter, or if it is more than 24.5 millimeter, then there are various sort of formula, there are various modifications in the formula that you are going to use. Similarly, in the keratometry, the difference between the two eyes should not be more than 1 diopter, and also the difference between the K1 and K2 of each eye, that should also be not more than 1 diopter, right? Because if it is more than 1 diopter, that means the post-operatively, the patient will have a residual astigmatism, so that means you can plan for a toric IOL in such patients. The average keratometry value of a normal patient is between 40 to 47 diopters. Now there are various generations of the formulae, right? From the first to the fourth generation, there are certain modifications that have been applied and they are more effective. Okay, so in the first generation, you have the SRK basic formula. The SRK2 is in the second generation. The third generation has SRKT and the Hoffer-Q Holiday, and the fourth generation has Holiday 2 and Haig's formula. So there are two types of IOL formula. One is a regression and other is a theoretical. In the regression formula, these are basically derived from retrospective computer analysis of post-operative result of a large number of patients who have already undergone cataract surgery. And a theoretical formula is something which is derived from the geometrical optics, considering the eye as a schematic eye. Now these are the types of formula. There are data-driven, optical approach, and hybrid, in which is a combination of both the data-driven and the optical approach formulae. Now talking about the basic SRK formula, this is something which everybody should be aware about, right? So this is A is the A constant of the IOL, that you're going to use, minus 2.5 into axial length, minus 0.9 into keratometer. So if you don't have any fancy machines with you, and if you know correctly the axial length of your patient's eye and the keratometry, then you can simply use this formula and calculate your IOL power manually. But what is important in this formula is that it has to be, the axial length should be between 22 and 24.5 millimeter. Now why is that important? For longer eyes, that means if the axial length is more than 24.5 millimeters, so according to this formula, it is going to calculate a stronger IOL power. Okay, so that means post-operatively the patient is going to have myopia, whereas if the axial length is less than 22 millimeter, right, for shorter eyes, it is going to calculate a weaker IOL power. So that means post-operatively the patient is going to have hyperopia. Okay, so that is why having a correct axial length and keratometry is extremely important, and looking at these powers between the two eyes and in between the same eye also, it is very important. So what are the modifications now that have been done in this SRK formula is, as we have already discussed, that for a shorter length you calculate a weaker IOL power, and for a longer axial length you calculate a stronger IOL power. So that means if the axial length is less than 22 millimeter, you need to add something to what you are calculating in your SRK formula, and if the axial length is more than 24.5 millimeter, you have to subtract so that you are calculating your correct IOL power. Okay, so these are the modifications in the SRK and the modified SRK2 formula. Now, the newer generation formulas, apart from using the axial length and the keratometry, they are also incorporating the anterior chamber depth, the white to white diameter, and the lens thickness. Okay, so that is how they are calculating your accurate and effective IOL power. Now, I'll quickly discuss one case scenarios so that you understand what is the use of these formulae. So this was a 40-year-old male which presented with gradual diminution of vision in both the eyes since the past 2 years. So the patient had cataract in both the eyes. The left eye has a higher grade of cataract. Now if you see at the axial length parameters, it is showing in the right eye 30.1 millimeter and in the left eye 30.2 millimeter. That means the patient is a high myopic patient. Okay. So we have calculated the axial length using the A scan and the optical IOL master, and we have calculated the keratometry also using the auto keratometer and the optical IOL master. Now, if you see the IOL power that has been calculated using the different IOL formulas of the left eye, the SRK formula is calculating the power as 5.5 diopter, right? And the SRK-T and the Holiday 1 is calculating it as 2 and 1.5 diopter. So you can see there is a huge, wide range of difference in the standard SRK and the SRK-T or the Holiday 1 formula, right? So if you calculate the simple SRK formula in such a case and you put a 5 diopter lens, then post-operatively you will have a huge refractive surprise, right? So that is why knowing which IOL formula to be used in which case is very important. Okay, so for a high myopic eye, an SRK-T and Hagees is generally the standardized formula which will give you a correct IOL power. So just to conclude, for very short eyes, that is which is less than 19 millimeter, we use the Holiday 2 formula. For eyes which are less than 22 millimeter, we use Hoffer Q. For normal eyes which is between 22 to 24.5, we use the SRK 1. For eyes up to 26 millimeter, we use Holiday 1. And for excessively longer eyes, more than 26 millimeter, we use SRK 2. And right now, the current formula that is being used is the Universal Barrett's formula, which is the newer generation formula. Thank you.
Thank you, Dr. Alisha. Any questions from the audience regarding IOL formula calculations? I think this is something that you really need to know very well, primarily because you'll have different axial lengths. At least in our country, there's a wide range of axial lengths that are available. So, yeah, I think that's well done, well covered. We'll have the next talk by Dr. Sakshi Jain, who's also faculty at the GMCH, and will talk to you about the different types of IOLs available.